Okay, so just give me a moment. I will hop over to Facebook and ensure it is streaming. Yes, it is. We are live. And as always, people waiting and joining the room quickly, which we love to see. So let's not keep them waiting any longer. Let's start the show. Hello, everyone. Welcome back to Luncheon with the Experts at Carcinoid Cancer Foundation and Neuroendocrine Cancer Foundation. My name is Rain Bennett. I am your host this episode and every episode. We are a little bit ahead of schedule because I was on vacation a couple of weeks ago. So instead of our normal 2-week cadence, we had an episode last week and we're back this week. So I'll go ahead and tell you, if you see someone or don't see them rather, who should be here, who's typically here as you're starting to sign on, tag them in the comments, share this video with them, let them know the show is going on today. I, if you don't know, am a filmmaker and a writer that's been working with NCF and CCF for a long time, over a decade now, creating hundreds, maybe thousands of videos, to be quite honest. I've lost count over the years, but all with one mission in mind, and that is to spread awareness and education about neuroendocrine tumors. Now, if you are new to this journey or new to this show, I want to say welcome. And you might see people in the comment section already saying hello. I got to tell you something. My best advice for you, if you are new to this show or new to this overall net journey, embrace the community. They will embrace you back. It is one of the most supportive communities I've ever seen, certainly ever been a part of. It is profound to witness every single day. So that's an easy way to initiate that connection, that engagement, is by saying hello, telling us where you're signing on from. I find that it's just as valuable to hear the shared stories and shared experiences from people that are going through this as well. Just as valuable as the information that you will get from our guest presenters today, our guest presenter rather. Now, speaking of which, I'm very excited because this doesn't happen so often anymore. We've been running the show for 5 years. We have a first timer on Luncheon with the Experts, Dr. Shagufta Shaheen. Dr. Shaheen, welcome. How are you today?
I'm doing very well. Thank you, Rain, and thank you, the foundation. Thank you, Lisa. I'm seeing her. Hello. So I really, really appreciate this opportunity. I'm honored and humbled to be here. I just hope we have a good 1 hour session and we just all kind of have fun on this.
Yeah, I'm sure that we will. Now, for folks that may not know you specifically and where you work and what you do, tell us about your background, in terms of nets and the role that you fill in this net community I was mentioning.
Absolutely. Well, good morning, good afternoon, and good evening to everyone, wherever you might be. As Rain mentioned, I'm Shagufta Shaheen. I'm a medical oncologist, and I work at Stanford. I primarily care for people with neuroendocrine tumors and neuroendocrine carcinoma, mostly extrapulmonary. I do see some pulmonary neuroendocrine tumors, but my majority of my practice is extrapulmonary neuroendocrine tumors and neuroendocrine carcinomas. A little bit about me. I grew up in Kashmir. I have been in United States for 20 years now, so this is my home now. I trained in various places. I trained in Chicago. I worked in Massachusetts, and then I decided to go in oncology after being a general medical doctor for several years because oncology was always where my heart was. So I trained in Loma Linda University in Southern California for my fellowship, and then I was really fortunate that there was this opportunity of training in neuroendocrine tumors. So I trained 1 year only focusing on neuroendocrine tumors and learning about it through none other than Dr. Kunz, who's the best. I feel very, very fortunate and really grateful that I had the opportunity to meet her and she mentored me. And I just love taking care of neuroendocrine people with neuroendocrine tumors. I feel like you guys have a great community. We have people who we connect with over the years, and just it's so grateful and so humbling, and I feel a lot of gratitude taking care of you guys.
Oh, I appreciate that, and big shout out to Dr. Kunz, who is definitely a friend of the foundation and a friend of the show. We love having her on here, and what a great mentor to have. I think a question: when you had that opportunity to do the 1-year program focusing on NETs, what was it? Do you recall what it was that made you say yes to that opportunity? What intrigued you about this field?
So I will say it was my interest that had just started, and then it was also what was happening in NETs at the time.
Mm.
So when I was a fellow, for whatever reason, my clinic attracted a lot of neuroendocrine tumors, and I have to be honest, I didn't know a thing about neuroendocrine tumors at the time, but it was such a different, and I would say it falls on a spectrum. The nuances, the not only your education, the data, but it also knows some art to it. So that breadth to it and what we could do for neuroendocrine tumor patients really piqued my interest. And interestingly, at around the time, which is about 2018, is when Lutathera was approved, and like I was like, wow, this is such a cool concept, and such a different treatment, like one of its kind at the time. So that kind of compounded it, and I it just so happened I was in ASCO GI, and this fellowship was announced, and I was like, wow, this is everything is coming together. It's probably meant to be. And when I met Dr. Kunz, I was just totally floored. I was like, oh gosh, I hope I get it. And I was like really, really lucky to get that opportunity. And that's
Awesome.
how my net journey started.
I appreciate you sharing that. I'm always interested in everybody has unique paths to this field, to this disease. So I'm always interested in learning about that. I appreciate you sharing. Folks, go ahead and start sending in your questions. I see some are rolling in. In the meantime, I've got a couple small announcements and some best practices. Those of you who are regulars, you know what I'm about to say in terms of best practices. The best way to get your questions answered is in short, generic chunks. If it's super case specific or super dense with detail, it's hard to field in this format. Dr. Shaheen will ask you if she needs any clarification to better answer your question, but just consider that, because there's no limit to how many questions you can ask. So you can always ask follow-up questions. So think what the most important you're trying to get an answer to, and then go down the line like that. Just helps us, with shorter generic chunks. And an announcement, I alluded to this at the beginning of the program, talking about all the hundreds, maybe thousands of videos I've done with the foundation. Well, one of the patient-centric documentaries that we are constantly producing was just premiered this week on Tuesday. It is the story of one of the most loyal friends of the show, Shane Peters, and his mother, Ilka. So it's really a story about support and caregivers and family and community, all of the things that we stand for here. So go check that out if you haven't seen it. It's on YouTube and on the Facebook, and please share that with anybody. Our goal with these is to tell human-centric stories that can appeal to everybody. You remember that part of our mission, to spread awareness, right? So of course it's for the NET community, but it's also for the larger community, for someone who might be dealing with symptoms, not know what it is, and have seen some of our work and be like, oh, maybe it's that. So that's our goal, is to spread this wide. So please share those, comment, like, any of that engagement helps the algorithm so more people can see that. Again, it's available on YouTube as well as Facebook. And speaking of YouTube, looks like we got good numbers growing from there this week, which is nice to see. All right. Unless we have any questions for me, let's go ahead and start the show. First question, Dr. Shaheen, comes from Lynn. Lynn says, I have a PNET with METs years ago, but through treatments, scans are all okay. Great news, Lynn. But the problem is Lynn can't gain weight. Is there any medication that could help? Lynn's appetite is fabulous, but just can't quite gain the weight that she needs.
That's a great question, Lynn. I totally understand, what you're going through. A lot of our patients who have neuroendocrine tumors, whether it's small bowel or pancreatic NET, they do have this challenge, even though the appetite is good, but somehow they cannot gain weight. Well, before we talk about medications, I think we want to make sure that we understand what the reason behind it. It could be that there could be malabsorption. I don't know your whole history. If you've had surgery, uh, pancreatic surgery, that can cause malabsorption, and there are things we can do to help, like pancreatic enzymes, something called creon. Then there are other things, like when people have surgery, they have diarrhea, another cause for malabsorption. So all of those things could lead to people not gaining weight despite having good appetite. There are some medications which we reserve only when we have explored other causes and try to kind of address those. Those medications have their own portfolio of side effects, mostly blood clots and things like that. But we also work very closely with nutritionists, and they may ask some detailed questions about what you're eating. They may give you some advice as to what you should be eating and how to kind of go about this. In the end, medications are there, I would say, as a last option. But considering, their side effects, we have to kind of balance then risk benefit ratio.
Oh, I'm muted. Got it. Thank you. And thanks for your question, Lynn. Please let us know if you have another one. I want to say hello to Tom from Liberty Lake, Washington. Tom, coincidence. I just booked our next patient-centric documentary, which is in kind of your neck of the woods. It's in Leavenworth, Washington, so I think it's about 3 hours west of you. But yeah, stay tuned for that next documentary that's coming out in a couple of months. Question from Charlene. Charlene says, could you please explain the difference between beta and alpha PRRT? This is a very common question these days.
Absolutely. Another, great question. And I mentioned, like, when I was training, that's when Lutathera was approved, or lutetium, or something called PRRT. Now, there are what Lutathera is. I want to take a step back and explain what that is. Neuroendocrine tumors have very specific receptors, and this Lutathera is a radiation given IV. Usually radiation is given in beams, but this is given in IV. The way we do it is we attach a molecule or something that goes inside our body. So there's a target, and then there's radiation put on top of that, and you give this IV, and that target kind of finds your neuroendocrine tumor and attaches to it, and that way it is all engulfed inside by the tumor cell. So it is a targeted radiation. Now, there are many radionucleotides that we can use. Commonly, what is approved right now is a beta particle. So the beta particle is a little bit bigger. It has, I would say, moderate energy, and it something called path length. All these radioactive substances or ligands have path length, meaning how far they can go. So the beta particle has a little bit longer path length. So the energy, I would say, if you quantify it, somewhat moderate. And when you look at alpha particles, so lutetium is like Lu-177, and the alpha particles is actinium or lead 212. So these are smaller particles, but they are much higher in energy. They're like a hydrogen bomb. You can, just for comparison, but they're smaller particle, but they have much higher energy than the beta particle, and they have a shorter half-life, meaning they are more targeted. So the what we call off-target effect, meaning the normal cells around the cancer cells aren't affected as much. And because they have higher energy, they cause more damage to the tumor cell. So our cells have DNAs, and they're like a string. These are double DNAs. So alpha particle is supposed to cause double DNA damage, whereas the beta particle causes single DNA damage. And we feel like, hypothesis is that beta particle eventually has resistance because of that, and alpha particle hopefully will have less resistance. Obviously, these are all alpha trials are in trials, so we we don't know the long-term, their effect and outcomes. So, but that's the difference between the alpha and the beta particle.
Got it. Thank you so much. Appreciate your question, Charlene. Caroline says, you just mentioned Lutathera. This was in reference to the first time you mentioned it. Do you think initial treatment of NETs will change with the NETTER-2 data and newer radiotherapies in development? You can expand on NETTER-2 if you'd like to.
Great. Another great question. If you look at the pivotal trial that led to the approval of Lutathera in United States was NETTER-1, and this was like a follow-up to that. The difference was the NETTER-1 included people who had already had other treatments, and they were lower grade tumors, grade 1 and 2. NETTER-2 is a different trial in a way that you are looking at what if we kind of sequence Lutathera up front, but that trial included higher grade tumors, meaning grade 2 and 3, but grade 2 were like people who had something we call Ki-67, which is a proliferative index that a pathologist gives us, which we can talk about, I think, as we go on. So that trial looked at people with a higher grade 2 Ki-67 more than 10 and grade 3 Ki-67 up to 55%. And these were people who were newly diagnosed. They were treatment naive. They had not received any somatostatin analog or any other treatment, and they had DOTA positivity. For us to give Lutathera, you have to have DOTA positivity, meaning DOTA scan is looking for a somatostatin receptor, and that's what this Lutathera binds to. So that was a positive trial. The design was very much like NETTER-1. So I think it's one option. It's not the option. It's certainly something we could consider for certain patient population. I don't think this is going to be like practice changing in a way that every grade 2 neuroendocrine tumor patient who has a Ki-67 more than 10 would necessarily need this upfront.
Got it. Thank you. Thanks, Caroline. Next question comes from a soon-to-be patient of yours in September, Katrina. Katrina says, I had a pancreatic NET or had pancreatic NETs 18 years ago with a Whipple done at Stanford. I've had a recurrence and I'm now on octreotide injections. However, I have every side effect of this medication. And so the question is, what are the other options for treatment for Katrina?
Hi, Katrina. I'm sorry about the diagnosis, and I look forward to seeing you next month. So what I understand is your initial NET, I'm assuming, was resected, and now it's back, and you are on a somatostatin analog, either octreotide or lanreotide. They're both very similar. Sometimes people have difficult time tolerating them, and the intolerance can be many things. So some people will have diarrhea, which kind of is counterproductive because we want people to have, this essentially controls diarrhea in patients with carcinoid syndrome that have diarrhea. But sometimes, because these injections also cause decreased secretion of pancreatic enzymes, can lead to what we call steatorrhea, and that may be why people have diarrhea right after the injection. But generally it gets better, and over time people kind of, I would say, they don't have as many side effects. So it would be helpful for me to know, when you say you're not tolerating them, is it that, or is it some people, if they have diabetes, that can be poorly controlled because somatostatin analogs can cause both hyper and hypoglycemia, meaning both higher blood sugar numbers or lower, most commonly higher. So I think it will be a little bit helpful to understand what are the symptoms that is like making you not tolerate this.
Got you. Thank you, Katrina. And of course, let us know if you have any other questions. This would be great to kind of like get some of the initial ones answered before you all meet, and hopefully we can get another.
I, I do I do want to follow up to that.
Please.
I think their question also was what are the other
Yeah.
options. So if we find that there are whatever side effects you're having that we can't control them, sometimes we reduce the dose and see if that works. If none of that works, we have to see what is the disease burden, where is the disease, and then decide what we can do. Sometimes we don't have to do something right away if things are stable. For example, if the disease is only in the liver and there is progression, meaning growth, there are things we can do very targeted to the liver, what we call liver directed therapies, and that encompass something called transarterial chemoembolization, bland embolization, radioembolization, and that could be an option either now or in future, or if there's disease outside of the liver and that is progressing as well, and you have DOTA expression on the DOTA scan, you know at some point, then we'll consider PRRT if there is progression. If there's no progression, sometimes we monitor, especially if the tumors aren't secreting any hormones.
Got it. Thank you again, Katrina. And I'll reiterate once again, if you have any follow-up questions, just let us know. Mara says, what are the criteria for a good prognosis, besides a good doctor, in a metastatic NET? And Mara was diagnosed 8 years ago.
Okay. Mara, thank you so much for this question. Again, it's a loaded question where we want to make sure we kind of make sure we understand what the disease is, what the disease pace has been, what the disease, where it's located. So just to take a step back, what are the good prognostic factors for a neuroendocrine tumor? I would say the first and foremost is differentiation. As you know, neuroendocrine tumors are now classified in something called, like, there's a big like a nomenclature called neuroendocrine neoplasm that has two buckets, something called neuroendocrine tumors and then neuroendocrine carcinomas. So this is a very important differentiation. I call neuroendocrine tumors the good guys and neuroendocrine carcinoma the bad guys. And within the neuroendocrine tumors, the good guys, we have further three categories: grade 1, 2, and 3. And then when we are assessing a neuroendocrine tumor, we want to know whether or not, in addition to the grade, what is their DOTA expression, which is, in other words, whether or not these tumors have somatostatin receptors. So I think at the outset, if there's low grade, they're well differentiated, they're low grade, and the disease is not volume wise, like disease is only limited to the liver, and it has been, if we have followed it enough and we understand that the pace is not very fast and there is somatostatin expression. So these are, I would say, the most common things which we try to assess initially and are generally good prognostic. There are other nuances to it, but I would say, like, these are my top three things that I want to look at, and that gives me a sense how you might do.
Got it. Thank you. And thank you, Mara, for your question. Next question comes from D over on YouTube. Hey, D, welcome. D says, I read an article that 2 centimeter PNET size for surgery that started now recommending treatment for 0.5 centimeters to 1 centimeter. What are your thoughts? Does that make sense? Did you follow that question?
Yeah. So it's kind of, I would say, evolving. What we know from our studies is, at least that was the thought initially, and that was in our guidelines, pancreatic tumors that are low grade and are not functioning, meaning they're not screening any hormones, and are less than 2 centimeter, it was appropriate to watch them. Low meaning, grade 1, and low grade 2. However, there is a large case series which looked at all these sizes, And what they felt was between 1 and 2 centimeters, there is a possibility that it could go to the nodes. So when at Stanford we assess someone who has a 1.5 centimeter tumor and it's low grade and they're not hormone secreting, I think if the patient is young, it's if the patient is old, obviously you have to really weigh risks and benefits. If the tumor is in the head of the pancreas, that requires a much extensive surgery, and the patient is 80 or 85 or 90, obviously we don't want to have them go through a big surgery that has morbidity and mortality of its own. However, if the patient is younger and the grade is higher, between 1 and 2 centimeters, I think we have a very detailed discussion about pros and cons about waitful watching. Um, and I think surgery for those tumors is not unreasonable, especially if they are higher grade and patient is young.
Got it. Thank you. Thanks, Dee. Let me know if you have another question. Next question comes from Cheryl. What are your thoughts about the association between chronic PPI use and the development of gastric nets?
Yeah, that is a very hot topic recently. I think, 30 years ago or 20 years ago, we were not using proton pump inhibitors as more widely as we are now. And over the years, we have learned there are many side effects to it, some of them being pneumonia in older people, or bone health is an issue. Obviously, if someone needs to be on it long term, it is totally valid. But for people who may not necessarily have a really a scientific or like a medical reason to be on it, yet they are on it, for many, many years, there is a very high chance that people can get neuroendocrine tumor of the stomach. And that is because you're suppressing the acid secretion, which in turn our brain thinks that, oh, we don't have enough enough acid in our body and we need to kind of make more. With the result, some of the cells are like our body asks them to grow so that it can compensate for that. But as a result of that overstimulation, the cells, which are some of the cells, our body has neuroendocrine tumors, neuroendocrine cells throughout the body. These are like normal cells, but what happens is there's like increased stimulation, and people can have neuroendocrine tumor of the stomach as a result of that. Now, I do want to mention that these neuroendocrine tumors of the stomach are pretty, I would say, low grade, and something that we can manage without having to go through like anything systemically, meaning shots and other aggressive things. Usually we look at endoscopies done frequently and then annually, and for most part, like cutting these tumors is is what is adequate or is enough. But at the same time, we want to analyze whether or not the person who is taking these PPIs are really like indicated.
Got it. Thank you. Thanks, Cheryl. Folks, if you joined us a little bit late, this is Luncheon with the Experts, an NCF and CCF program. We are here with Dr. Shaheen from Stanford. Great questions so far, and we are halfway done. We're moving along quickly, so we're going to keep plugging along and hopefully get to all of your questions. The next one comes from Noble. Noble says, I'm 31, just got diagnosed, found via grade 1 Ki67, 2% liver met, that is 9.4 centimeters, and cystic. The question is, are there any effective first-line treatments for G1 tumors to shrink a large cystic mass? My doctors are going for extended right hepatectomy due to the mass being so central and near core structures.
Yeah, we encountered this a lot when we see people with a liver, bulky liver tumors. I think the question is, you mentioned that it's a lower grade. Am I correct? You said cystic, but I'm not sure if I heard the grade.
Yes, grade 1, Ki 67, 2% liver met.
Okay. Okay. So, um, what we want to know for when we are thinking about whether or not these tumors need to be shrunken is where it started. Um, if most of the tumors start in the small bowel, sometimes we cannot find them. And the reason I'm mentioning it because if the tumor started in the pancreas, there are more effective treatments to shrink the tumors as compared to when it started in the small bowel. We talk about these cases in our multidisciplinary tumor board, which is really a very important part of net care. And if a surgeon thinks they can take it without the risk of something leaving behind and it's going to be beneficial and help them with the surgery, especially save the liver, and if the tumor started in the pancreas, we will start a chemotherapy called capecitabine and temozolomide. And that's generally very effective in pancreatic neuroendocrine tumors that has spread to the liver, and sometimes that helps us with the surgery, making it a little bit easier and um, higher chance of this tumor coming on block, meaning entire of the tumor is out. But if it's small bowel, I am not sure we have effective treatment to really get to shrink those tumors. So if the surgeon feels that he can take it out without having to shrink this tumor, and because it also is really dependent on the location. If it's really in one lobe and all they can do is just take that segment out, that can be done if it's small bowel tumor that spread to the liver.
Got it. Thanks, Noble. Next question from Charlene. I did PRRT in 2022 with good stability for 2.5 years, but the latest scan shows some activity. This is kind of case specific, but I think you can still address it in general. Would you recommend alpha PRRT or another TACE procedure?
So seems like you had good stability or you had response and the tumor kind of stayed stable about 2.5 years, which is very typical. This is what we saw in the NETTER-1 trial. So it's kind of tracking along to that. Now the question is, if it's come back, where has it come back? If it's growing, sorry, you have stable disease, but if it's growing, where is it growing? If it is, I don't obviously know the distribution of the disease. If you have liver dominant disease, meaning if the tumors are mostly in the liver and that's where it's growing, thinking about a liver directed treatment is perfectly appropriate, and we do that all the time. But if it is more widespread and it's kind of growing multiple places in liver and outside of the liver, then the next step would be choosing another systemic treatment. So as you mentioned about the alpha PRT, it's right now only in investigational, and we have trials for that. And if you are a candidate, you could consider the trial called Action 1, which is looking at alpha PRT, but it's a randomized trial, meaning you have 50% chance of getting alpha PRT. That is if you're deemed eligible, meaning your kidney numbers have to be what the trial is looking for, your albumin and other things. But you have to understand that there's a 50% chance of going on an arm that is not upfront alpha PRT. And that on that arm, your physician can choose whatever he feels he would do, not the beta part in PRT. It cannot be like Lutathera. But the thing is, it's a crossover trial, meaning if your physician, I'm just saying, we have the opportunity of doing double dose somatostatin analog or everolimus or sunitinib, depending on where the primary tumor is. If you ultimately progress on that or have side effects that you just can't take that treatment, then and on that your tumors progress, meaning they're growing significantly. There's like a terminology like it has to grow 20%. we have to kind of meet those criteria of like what we call a significant progression. At that point, there is an opportunity to cross over to the alpha PRT arm. Again, if you meet eligibility criteria at that time. So alpha PRT, in short, the alpha PRT right now is investigational, and I would prefer that for my patients, but it's only on the trial.
Got it. Thank you. From Melissa over on YouTube, I have multiple recurring type 3 grade 2 gastric nets. Are there any new treatments for type 3 nets other than surgical resection?
Yeah, the type 3 is less common, but is more aggressive than type 1 and type 2. If it is localized to stomach, surgical resection is what we prefer. Now, if it is, God forbid, if it's like traveled outside of the stomach and if it's in the liver, you kind of treat them as you would treat other metastatic neuroendocrine tumors. If they have somatostatin receptor positive, meaning if they're DOTA positive, you can start with octreotide. Again, depending on what grade it is, like what is the Ki67 and how fast it has been growing. Sometimes we also use chemotherapy because we are afraid that these are higher grade tumors. Now we have another pill that was approved called cabozantinib. It's not a chemotherapy, but it's a very targeted therapy that can also be an option. So cabinet trial was the trial. I think one of the first trials in our targeted agent trials that we had so far, which included grade 3 neuroendocrine tumors and kind of all primaries, including gastric primaries.
Got it. Thank you. Thanks, Melissa. Next question from Daniel. Daniel says, I had a 3 centimeter appendiceal carcinoid at 25. I had a right hemicolectomy. Continued with 24-hour 5-HAAA for 10 years and gallium nuclear medicine scans and PET scans over the years. Anyways, I am now 67 and symptom-free as far as I can tell. That's great, Daniel. What is the best test I can request my primary care physician to do, and how often should I?
Daniel, I would say congratulations. Looks like there's no tumor at 10 years. That's great news. I would say of all the primaries, appendiceal primaries actually do very well. I'm not saying they never come back. They could come back, but they're generally well behaving. It seems like you've had what we call completion right hemicolectomy at the time of diagnosis. And you said they were checking hormones. I'm assuming they were also checking scans.
Yes, I think so.
Annually. So if that is the case and you have completed 10 years, that our general guidelines are we surveil people annually with either an abdominal MRI or a CT. We prefer MRIs because it spares radiation. And if that has been done and you've completed 10 years and graduated from your oncologist, generally, you can just go by your life. You can go and do your, regular screening, colonoscopy, depend on that, when it was the last colonoscopy, what they found. In my practice, sometimes I will go a little bit over 10 years, and that is if the person was diagnosed like very early and they had features that are high risk and all those like nitty-gritty details. It's not unreasonable to do another MRI for a couple of years. I have certainly seen a recurrence after 10 years, but it's like very, very few patients, not appendiceal, mostly small bowel or pancreas. The risk is really low, but it could happen. It may not happen with appendiceal nets, but you're young and doing another scan. You could do another scan in 18 months or 2 years, generally an MRI or whatever your scans you have been doing.
Got it. Thank you. And thank you, Daniel. And you might be able to see in some of the comments that your story is inspiring to other patients here on the show. That's exactly what I was talking about at the beginning of the program. These shared experiences and shared stories are just as helpful, valuable, powerful as the medical information. So appreciate you sharing that, and that is good news. Next question from Marcel. Marcel says, "Are you able to join a clinical trial for alpha PRRT if you haven't done beta PRRT?"
Yes, exactly. Martha, I was just mentioning there is this Action One trial that is basically for people who have had PRT and had good results, meaning they had response or stable disease for 1 year, and if they if they have now progressed after being stable for at least a year, Action One trial is for them. Again, the caveat is that 50% of the patients may get randomized to what we call standard of care arm, where your physician will choose what else they would do outside of PRT, but ultimately you'll get a chance to cross over. Um, we have that trial open at Stanford. It's going to close kind of soon. I think they're like very nearing their accrual goals. So that's something that you can talk to your physician. If they don't have it open there, they can refer you to somewhere close by where it's open. Again, with clinical trials, we have to be very cautious because these are all experimental things. And, you know, the first principle of being a doctor is do no harm. So we want to make sure that you are actually a perfect candidate for that. That means looking at your kidney numbers, your hemoglobin, your albumin. There are like multiple criterias that what we call eligibility criteria for people to get into clinical trials. And if you meet all of those, then it's certainly an option for you.
Thank you. Next question from John. John says, "I'm an 86-year-old male with carcinoid liver cancer being treated with lanreotide as surgery is too dangerous. The question is simply, what is your take on lanreotide? So what information and guidance could we give to John about that?"
So I want to clarify. I think it's neuroendocrine tumor, probably not neuroendocrine carcinoma,
Fair.
or I heard the word cancer, um, and it seems like it started somewhere. The most common, as I said, is either small bowel or pancreas, and if we feel, um, people who have this disease are not a good surgical candidate. Again, do no harm. If we feel like surgery has a risk that it kind of is outweighing any benefits, then we look at what do we have next. Again, um, somatostatin analogs are the first line of therapy for most grade 1, 2 neuroendocrine tumors that have DOTA positive, that have a positive DOTA scan. So that is perfectly, okay, and that is what I would do for my patients. It depends. Now, if we have a patient who has symptoms, meaning they have pain related to neuroendocrine tumor, they have large tumors in the liver, they have large tumor if it starts in the pancreas or in small bowel, sometimes we may not want to do full on debulking surgery, especially if it is small bowel tumor. We may want to just take that primary out, the small bowel tumor out, because down the line it can cause problems. But if it's a pancreatic neuroendocrine tumor, then you can start with a somatostatin analog. There are other things depending on how fit you are. One can use chemotherapy. Again, that generally when people have symptoms and we want to shrink those tumors. And then, of course, down the line, PRT is an option if things start growing on the somatostatin analog.
Got it. Thanks, John. Let me know if that answered your question or if you have any other information or follow-up questions for us. We've still got 15 minutes. Next question comes from Sarah. "My 29-year-old son has a PNET that is involving the portal vein. A stent is recommended. The question is, are there any limitations on activity like hiking, biking, skiing at altitude when one has a stent?"
Sarah, I'm sorry to hear about your young son having to deal with this diagnosis. Um, I would say if he needs a stent, it seems like um, there is some kind of blockage, and that generally is related to the tumor. Now, what we see most commonly is stent in, we see blockage in a biliary tract. People can present with jaundice. Um, Either way, if the stent is needed in either biliary tract or portal vein, if the stent is deployed and there's no complication, he can just listen to his body, and he can do whatever activities he wants to do. I'm hoping that you are seeing a net expert or a net surgeon. If the tumor is localized to pancreas, depending on how big it is, he's only 29, considering, surgical options. Also, at that young age, we want to make sure that they have been referred to cancer genetics, and make sure that there's nothing familial going on, and whether or not they may need some other testing.
Got it. Thanks, Sarah. Julie says, in addition to PPI use long-term for acid reduction, are GLP-1s long-term for DM type 2 responding well involved in causing GNETs? I think we had a similar question earlier. Did you follow that?
Okay, so for yep, I think there's like two questions in one question. So as we talked about earlier, a long-term proton pump inhibitor use or PPA use um, can lead to low-grade gastric nets. And we talked about like how to manage. Again, yeah, if someone needs to be on it, then they need to be on it, and then they get endoscopies every 1 to 2 years, depending on like what we are finding on the endoscopies, what the grade is, and whether or not they need something additional. Again, how big the tumor is, what the grade is. Now, for the GLP-1, I'm not aware of any increased risk of gastric net or any net. However, there is a theoretical risk on people who have what we call MTC or medullary thyroid cancer or history of thyroid cancer, or they have a familial syndrome called multiple endocrine neoplasia type 2. So in rats, like in preclinical studies, they had seen that people with these conditions, the GLP-1 can increase, the tumor growth. Outside of that, I think we're perfectly fine with people taking GLP-1 class drugs.
Got it. Thank you. From Noble, what is the future of chemotherapy for low-grade nets that are small bowel or non-pancreatic? Are there things in the pipeline being tested or trials, etc.?
Yeah, there are like, again, if something is not broken, we don't want to fix it, meaning and they are not screening any hormones, and the disease has remained stable, meaning the pace is not high. I think we can monitoring that's perfectly like reasonable, and that's actually in our guidelines. Now, if people need treatment, in addition to somatostatin analogs, obviously we have PRT, alpha PRT is being investigated. There is a trial that will hopefully start. It's going to be a very early phase trial where we are looking at a very cool concept like PRT. It is delivering what we call EDC, or you know it's a drug conjugate. This is a concept that we use in other cancers like breast cancer and other cancer, in which you're trying to target the chemotherapy to the tumors, meaning there is a peptide that, which is usually that somatostatin receptor analog, that will, that then it's a payload, a chemotherapy that's attached to that. Then it goes and finds that somatostatin receptor, binds it, and then delivers that chemotherapy, targets it just the tumors. So that's it's in very early development, and I would say by the end of this year or sometime in Q3 we may see it getting enrolled. But that's only for people who need treatment, meaning if their tumors are growing.
Got it. Thank you. Wasim says neuroendocrine tumor with Ki67 only 1%. Recent NGS shows nothing much but highlighted in HER2. I hope that's how you pronounce that. What do you suggest about dealing with in HER2?
A new diagnosis of grade 1 tumor. We don't know the primary though, right?
No, not that I see. I don't know how new, because there's a previous section where Wasim says I used cabozantinib for 1.7 years and it stopped working. Or Cabo. Are you able to see that question, Dr. Shaheen? Oh, looks like we lost her. I wasn't sure if that was on my end. Hey, everybody, any questions for me while we wait for her to sign back on? We've got a few minutes. Hopefully she makes it back. By the way, we added the link to the documentary I mentioned earlier and many other links in the comment section. So if you haven't seen that, you can scroll through and the link will be right there for you. But we always try to do that. The NCF team on the back end adds any resources that are mentioned in the show right there in the comment section, so you can easily access them. There she is. She is back. So if you had any burning questions for me, sorry, you won't have the chance to ask them. Maybe next time. Here we go. Hello, Dr. Shaheen. Welcome to Luncheon with the Experts, our 7-minute show. Sorry, I'm not sure what happened, but can you bring us back to where we were? Or do you want me to tee us back up?
No, I think we were talking about a neuroendocrine tumor that I'm not sure where the primary is. If I heard correctly, like what are the options? Is that correct?
Yeah, basically, what I got is neuroendocrine tumor with Ki67, only 1%. Recent NGS
Is
shown
it me
nothing.
or is it?
Oh, are we losing her again? No, we lost her again. Okay, team, we've got 5. I see some thanks to me. Appreciate you all so much. This is the fun part of technology. Sometimes connections are not perfect, but now you've got 5, maybe 6 minutes with me if you want to get those burning questions in. Otherwise, hope today's show has been good to you. We've got a few more questions, and Dr. Shaheen is back. We're going to try it again. We're going to keep going.
Sorry, I'm using my phone now, so
hey, I like it. We make it happen any way that we can. So the real question from that one, Dr. Shaheen, was, what do you suggest about dealing with in HER2? And I'm not familiar with that treatment or that medication.
So, and HER2 is a treatment that is, we use it in breast cancer and GI cancer. That's usually for adenocarcinoma who have HER2 mutation and people who have progressed on other therapies. Now, in neuroendocrine tumors, if someone has HER2 mutation, which is very, very rare, they're generally higher grade tumors. And if they have HER2 mutation, that could be an option. There are other HER2 target therapies. I hope that answers the question, but it's not for grade 1 and 2 where we have other options.
Gotcha.
And then, unless they have a HER2 mutation, that could be an option down the line if there is like progression and tumor is like faster growing.
And Wasim, just so you know, if you look in the comments just under yours, there's a link to reach Dr. Shaheen if you wanted to follow up. Wasim is in UAE, and so they were asking if they could get in touch with you for an opinion. Let's go. We've got 5 minutes. I think we can get to maybe two more. Melissa says, what does it mean if a copper dotatate scan shows a lymph node in the thoracic inlet lights up? Don't most gastric nets spread to the liver and bones first?
Can you repeat the question? Sorry, there was a bit issue
Absolutely,
with that.
yeah. What does it mean if a copper dotatate scan shows a lymph node in the thoracic inlet lights up? Don't most gastric nets spread to the liver and bones first?
Okay. So gastric nets, especially type 3, higher grade, can spread. You're right, commonly to the liver first, but it can go to nodes. So I mean, if it is like just one node in the chest, I think making sure that we know what it is, it depends on the location. If it's central, we can do, our lung doctors can do something called EBUS, put a scope and get some tissue to do the diagnosis. Or it can be non-specific. If it only lighting up on DOTA and we're not seeing it significantly on the CT scan, is it something that's inflammation? I think that's also to keep in mind. So generally we can do a short interval scan to see if it's getting bigger or it's getting smaller. That sometimes leans us towards one way or the other. And then ultimately, like trying to get the tissue to establish what diagnosis it is. But you're right, nets like to go to liver, but they do go to nodes.
Got it. Thank you. Next question from Dave. Dave says, do multiple primary nets in distant locations, the lung and the pancreas in this case, change prognosis or treatment? According to the research I have, only been able to find 2 cases where a lung net metastasized to the pancreas, and my lung net does not have, which was recently resected, does not have immunohistological features of pancreatic tissue. I tested negative for MEN1 in 22 and was diagnosed with NETs early this year. My pancreatic net will be resected in a few weeks.
Okay. So I would say having 2 primaries is not very common, but we have seen those. And getting metastatic disease in pancreas is also uncommon, but we have seen those. So both of those scenarios are possible, but they're not very common. Sometimes we deal with this dilemma as well. And, you can do NGS to both samples, and if they look similar, then you can conclude that it's probably net that started in lung and has gone to the pancreas. If they're like not, if they're discordant, like, you look at their mutational profile, that sometimes like helps us understand whether this may be metastatic or a second primary. These all kind of adjunct to what we are thinking, but ultimately, I think clinically, 2 primaries is not impossible, as well as metastatic lesion to the pancreas. Both are uncommon, though.
Gotcha. Thank you. I think that we have one more. Dolores was diagnosed in 2005 with small bowel. After that, 2 surgeries and PRRT. The tumors have multiplied and they've grown. And there's been 4 options given to Dolores, and Dolores would like a second opinion. Any suggestions? Let me know if you want me to repeat any of that.
I would say, like, really taking a step back and understanding where the disease is. Like, dotatate scan helps, like, what is the distribution of the disease? What is the volume of the disease? Is the DOTA positive? Have you had any previous treatments? If none, and it's like a new recurrence or a new, new distribution, then you have DOTA positive, you can start with somatostatin analog, especially if there's any hormone secretion, and then take it from there. I hope I answered the question. it was my connection, unfortunately, is a bit unstable. So I hope I heard the question and understood it correctly.
No, that's quite all right. That's we're at the top of the hour, folks, so that will be our show for today. But for anybody that does have follow-up questions, one thing I like to mention that we always have available to you is the support line. So reach out at ncf.net/support line, and this could be anybody, patients, caregivers, whomever, to get some answers to your questions between our episodes. We do these every 2 weeks, so we will be back in September. Let me just double check. Okay, September 4th. So Labor Day is a little bit early this year. So we will be back on the 4th with any questions that you have. In the meantime, reach out at the support line. You can find that at ncf.net/support line. Dr. Shaheen, thank you so much for being here. Thank you for being willing to jump to different devices to make this happen. I appreciate your commitment so much.
Thank you so much for having me. It was. I hope I helped, and I'm really happy to take any other questions offline. You can reach out to me. I think it's perfectly fine to share my email. Again, apologies about the connection. It never happens. It had to happen today.
Of course. Don't worry. It's happened to me plenty of times too. And I'm the host of this thing. So no worries at all. We make it happen however we can. I appreciate you being flexible. Folks at home, thank you as well for joining us. I hope this program helped answer some of your questions. Finally, my name is Rain Bennett. I have been your host. Thank you for watching. And please join us next time on Luncheon with the Experts. Stay healthy, stay